Good morning, good afternoon, and good evening, everyone, and a very warm welcome to this international webinar hosted by FH Europe Foundation. Today, we'll explore the cost effectiveness of testing for elevated Lp(a) and the Brussels International Declaration. What does this mean at country level? And importantly, how can our communities really get involved and engaged? We're in celebratory mood today, and we'll talk a little bit about that in a second. But if we can have the next slide. As I say, we're in really celebratory mood today. This is a group photograph from our first ever Lp(a) Global Summit, which was the brainchild and one of the key goals of the International Task Force. And on the next slide, you can see the members of this International Task Force, a very diverse group of individuals from across the globe, from China, from Japan, from Australia, real Lp(a) addicts, but also people coming from different disciplines to really have the breadth of knowledge and expertise to move forward on the importance of testing and people-centered management in the context of elevated Lp(a). So today it is my great pleasure to introduce our speakers, and we have three sterling speakers. Professor Florian Kronenberg, who's the chair of the Lp(a) International Task Force, author of the EAS consensus paper on Lp(a) testing, and is the head of the Institute of Genetic Epidemiology in Innsbruck, Austria, which is also my home country. And we thank again, Florian, not only for being here today, but all the amazing work that you've done as the chair, building up to the summit, and of course, a lot of the follow through afterwards. That's great that you're here. And we
It's a
have with us,
pleasure.
and we have with us also Professor Zanfina Ademi, Professor of Health Economics and Outcomes Research at Monash University, Australia. And Professor Ademi is a member of the International Task Force as well, an author of really important research that was commissioned by FH Europe Foundation to understand the cost effectiveness of Lp(a) testing, and also crucially from a societal perspective. A very warm welcome to you, Zanfina. Lovely to see you again, and really excited about your presentation. And last but not least, Inese Mauriņa, who is heading the patient organisation FH Parsidi in Latvia, which is also a proud member of the FH Europe Foundation network. And you, Inese, you're also a participant of a really important EU joint action project, JACARDI, focusing on CVD and diabetes prevention, among many other achievements that you have. So looking forward to getting your input about the Latvian situation a little bit later on in our discussions. So to kick off, we're meeting today exactly 1 week since day one of the Lp(a) Global Summit. And of course, the Lp(a) Awareness Day happening on an annual basis now, 24th of March. All of you were there and played an instrumental role in its success. Can I invite perhaps all of you to share just a few thoughts on the summit and its impact from your perspective, just to kick us off. And Florian, I'll invite you first of all to the floor.
Yeah, thank you. I think this summit was one of the best experiences in my entire career because bringing together top scientists from all over the world, together with people with lived experience with Lp(a), together with policymakers, I think this created a cocktail where we can expect something really exciting. And I think it starts now a dialogue and a momentum. And one of the goals is that we bring in Lp(a) in the cardiovascular health plan, in the plans in the various countries on the EU level and also the other countries. I think this will be really important. It will be important for our citizens.
Yeah, I agree. I mean, dialogue was really the word of the meeting, really deep collaboration among many different stakeholders, including the politicians in the room. So that was really great. Inese, what were your takeaways, your key takeaways?
Yes, thank you. These were really two very busy and also very interesting and very impressive days. And also, as Professor Kronenberg already said, it was a cocktail, a mix of, but what's the most important, that also patient voice was heard. There were also a lot of patient representatives, patients who already have LP little, high levels of LP little A, and also patient representatives of organizations like me, myself. And I was really surprised that so many actually important stakeholders, as well MEPs from Parliament of European Union, as well Health Commissioner. So spent the time and also participated with this event, stressing again that this is a very important issue regarding the prevention of cardiovascular diseases at all, and particularly raising a need also to improve awareness and also diagnostics of lipoprotein little a.
Great. Yeah. I mean, there was a really powerful presence from people with lived experience, and a dedicated session right at the beginning of the meeting outlining their perspectives and the impact of inertia in this space, which was really compelling. Thank you for that. Over to you, Zanfina. You flew a long, long way to be at the summit in Brussels. What were your takeaways?
Well, thank you, Nicola. As Professor Kronenberg and Ines pointed out, the summit had all the beautiful ingredients together. But if I would just sort of want to focus on from a health economic perspective, is that LPLA Global Summit really highlighted the importance of integrating LPLA testing into preventive care strategies. What stood out to me that identifying elevated LPLA levels early presents a real opportunity, not just for improving individuals' health outcomes, but for avoiding future healthcare costs by intervening before disease progresses. And if we are serious about value-based care at this point in time, then testing, risk stratification, and behavior modification, as was highlighted by a lot of our ambassadors, must be prioritized. So this for me stood quite a lot. And I think the momentum we've seen over the past week is very promising. And now the challenge is making sure that this awareness translates into policy and practice.
Absolutely. And the slogan was very, very loud and clear during the meeting, particularly from the people with lived experiences, the ambassadors: testing, 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 a very, very clear message. Super. So let's move on then. Can I turn to you, Florian, once again, to put a little bit of meat on the bone regarding elevated Lp(a), why testing, global risk assessment, and personalized management is really so important to really set the scene for us.
Sure,
Over
I
to
will
you.
do that.
Great.
Thank you. Yeah, I will start and tell you a little bit about LPA to set the stage. And I will talk about a little bit the journey. And the journey is already running since decades. We have a lot of science created in these decades. We have a lot of evidence that created consensus and created guidelines. Now the question is where to go. And I will talk first a little bit about background and epidemiology. We clearly know that LPA is the next target to fight cardiovascular disease after we have wonderful drugs to lower LDL cholesterol. And here you can see this LPA particle, which is LDL-like, but it carries also a further apolipoprotein called apolipoprotein A, and it carries a lot of oxidized phospholipids. And many people think that this is the real culprit for the atherogeneity. It's an independent and one of the most important causal risk factors for ACVD. It shows only minor correlations with the other lipoproteins. Therefore, if you do not measure it, you will not get the information which is in this lipoprotein. And the concentrations are mainly genetically determined. And we learned last year that it's a very atherogenic particle compared to the LDL particle. So when we look at the association between LPA and cardiovascular outcomes, we can clearly see a continuous relationship. That means the higher the concentration, the higher is the risk. And this is the case not only in the white population, also in the black as well as in Asian populations. And how often do we observe these concentrations? In roughly 70% of the population, in the white population at least, we see concentration up to 75 nanomoles per liter, where we say that the risk is not really increased by that. Then we have roughly 10% with concentration between 75 and 125 nanomoles per liter, where the risk is increased roughly 20 to 40%. But then we have 20% of the population, so each fifth person has concentration above 125 nanomoles per liter. So this is quite a number. And what you can also see from this figure, there's a difference whether someone has 150 or 350 nanomoles per liter. As I said, the higher the concentration, the higher is the risk. When we look at the situation with which outcomes, with which clinical outcomes is LPLA associated, we have wonderful data from Copenhagen, and this figure shows us what happens to those people in the upper top 5% of the LPLA distribution in the population. That means the 5% of the population with the highest concentrations, they have roughly 3 times the risk for a myocardial infarction or an aortic valve stenosis, doubled risk of peripheral arterial disease, and 1.6-fold risk increase for ischemic stroke. And please keep in mind, these endpoints are frequent and the high LPLA concentrations are frequent. So this is not really a rare situation. This has a great public health relevance. So is LPLA an independent risk factor? And again, when we look at big databases like the UK Biobank or in Copenhagen studies, in what subgroup you are looking at, whether it's women or men, whether it's young or old people, or traditional risk factor subgroups, or in primary or in secondary prevention, you will always see that LPLA is a risk factor in all of those subgroups. That means LPLA is an independent risk factor for cardiovascular disease, and you should measure it. There's an important reason to measure it, because you get a lot of information from this particle. So what do the international guidelines recommend? In the ES consensus panel, we recommended LPLA testing at least once in all adults to identify those with high cardiovascular risk. And if you have a person sitting in front of you with a high LPLA concentration, then the entire family should be invited to get tested. Because of this high genetic determination, you would expect that you find also other family members with high LPLA. And genetic testing is not required, which makes it much easier. A simple blood test measured in the lab, and you are done. And you know then what is your risk when it comes to LPLA. So why should I test LPLA when no treatment is available yet? This is a very often raised question and an excuse not to measure LPLA. And the basis for a good management plan is the estimation of the global risk of a given person. The global risk is really important. Or with other words, not even the biggest LPLA addicted person would only look at the LPLA concentration, but always in context with the other risk factors. And this is shown here in that slide, again, from data from the UK Biobank with more than 400,000 people, where we stratified people according to the number of traditional risk factors, which are listed here below and which we use in clinical practice. And on the y-axis, you can see the absolute lifetime risk for cardiovascular disease. That's not the 10 years risk, that's the lifetime risk. And if we group now in low, middle, and high number of risk factors, we can see that those with low LPLA concentration of, let's say, 7 milligram per deciliter or 16 nanomoles per liter, they have 5, 15, or 25% lifetime risk. When we go to those with LPLA 50 milligram per deciliter or 150 nanomoles per liter, the risk is increasing slightly to 7, 21, and 35%. But if we go to those with the very high LPLA concentrations, 150 milligram per deciliter or 350 nanomoles per liter, this is roughly 1 or 2% of the population. And we see here a pronounced risk increase to 14, 41, and 68%. And here it is shown the additional risk which is caused by LPLA. This can increase tremendously up to plus 43% if someone has a high number of traditional risk factors and in addition of this very high LPLA concentration. So that means if LPLA is not considered in the risk estimation, individuals at high risk may be overlooked and mistakenly classified as low risk. So in whom to test Lp(a), there was a paradigm shift during the recent recommendations, and meanwhile, we are recommending that everybody should get an Lp(a) measurement at least once in a lifetime. And this is started in Europe already in 2018. It was taken up by the consensus statement in 2022, and it is meanwhile adopted also in China, India, Canada, and also by the US National Lipid Association. And there is this shift to primary prevention, because we would like to avoid that someone is coming into secondary prevention, because when we know about the Lp(a) concentration, we can do a lot for those people already in advance to avoid this transition to the secondary prevention. The advantage of this recommendation is it's simple. There are no ifs and buts. It is part of a comprehensive risk assessment, and we have even a Lp(a) risk calculator available, this lpaclinicalguidance.com, to calculate the absolute lifetime risk for a given person. And most important, it guides early preventive measures. The challenges are also there. We have educational gaps, which we have really to focus on. It requires time for counseling of the given person, and currently there are no specific Lp(a) lowering drugs. And the reimbursement issue is also there in some countries, and this is very heterogeneous in the different countries. So what is an Lp(a) measurement good for? It's all about risk prediction and drawing the conclusions. This is a combination we have to keep always in mind. And I'm coming back to this slide I showed already before. And the message here is quite clear. Those who have a large number of risk factors or a middle number of risk factors, and in addition to the high Lp(a) concentration, here the reduction of the traditional risk factors is extremely important. And here starting prevention is here really the key. So the recommendation from the guideline is that those with high Lp(a) concentration, the focus is on early and optimal treatment of the traditional risk factors. And this is according to the various guidelines we have in place: stop smoking, lower LDL cholesterol, blood pressure, appropriate treatment of diabetes and prediabetes, and lifestyle changes. By that, you will not decrease the Lp(a) concentration, but you will decrease the overall cardiovascular risk of a given person. So starting prevention early is the key, and therefore we are focusing on the primary prevention. We would like to avoid that people are moving from primary to secondary prevention. We would act before they develop a cardiovascular event to avoid this event. So why are we here? As I told you, we have science, we have a lot of evidence, we have consensus, and we have the guidelines. Now, in a couple of minutes, you will hear about the cost effectiveness of Lp(a) testing. And from that, we can draw the implications for the implementation, because it's really important that we are focusing on those people who are really in need for the magic word prevention. And I think that's again and again important. We want to prevent cardiovascular events. So we are here for you guys. And each of us can be the one out of the 5. And please spread this message over the world. Test, 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 and test. Thank you.
Thank you very much, Florian, for that wonderful overview, and all of the messages and all of the science that Florian has shared with us. We've tried to encapsulate that within the Brussels International Declaration with very specific asks, backed up, as Florian said, by that science, by that evidence, but also the esprit and the perspectives of people with lived experience. So that was really great, Florian. Inese, I'd now love to hear from you. Let's move geography into Latvia, where you're from, a country with a relatively small population. What are the levers that you're using to bring about greater focus on inherited lipid conditions and testing specifically?
Yes, I can explain you from my perspective how this whole story looks, also what Professor Kronenberg just told. So let's say about 2 years ago, I've heard about Lp(a), but there was no information at all about it in Latvia. So I learned actually more about this risk factor thanks to FH Europe and meeting real patients who have elevated Lp(a) levels, and among them also very young people. And I was really surprised, and this was the first time I heard about it, that it's so really dangerous, and also that it's so widely spread. And then I came back home to Latvia, and I was asking also our cardiologists, also our doctors, so how come we are not talking about that? So of course cardiologists were aware about that, but patients know, because I also came to our patient group. I asked them, do they know, have they been tested? I asked also my father, who has coronary heart disease and who has already 5 stents, also despite the treatment, if he has ever been tested. And I also observed the opportunities in our country regarding Lp(a) and testing. And the good thing is that Lp(a) is tested in hospitals. But the bad thing, it happens only after patients already had heart attack or some other issues related to cardiovascular health. And but you can do it actually in almost every lab across the country. So this is also good, and these tests are not too expensive, but they are not reimbursed, and they are not so-called routine tests, so they are not included in this any kind of prevention panel. So if you want to be tested, you have to know that test, and you have to ask yourself. And also, according to our experience, also GPs, even if they are aware about the disease or risk factors, are not so keen to advise patients to do tests, like no kind of without reason, like no, why you have to pay it on your own, so why should you? And it's also understandable. It also makes sense. So yeah, actually, and this is how it all started in Latvia. We understood that we have to prepare somehow, also educate the basic education materials also for patients. So because when you type the lipoprotein A in Latvia, like a year before, you couldn't find like anything except scientific information. So right now, also in collaboration with FH Europe, we have prepared quite a lot of materials. We had also just a week ago a campaign also related to Lp(a), and we are starting to also reach out to patients who have or probably might have also high lipoprotein A level. And this is also one of the reasons why right now we are also discussing with our decision makers, because right now there is a cardiovascular disease or cardiovascular health plan being prepared also in our country and Latvia. So, and together with cardiologists, we are also stressing the role of prevention, but not just prevention in terms of lifestyle, because this is also important, but also regarding these different kind of genetic testing, also as FH, as lipoprotein A, and so on. So this work has just began, and I hope it will also move forward, also thanks to all these activities we are hearing today, and also thanks to this Brussels Declaration and cost effectiveness report we are about to hear very soon.
Great stuff. You're really using all of these materials as a springboard for changing the environment in Latvia with a coalition of the willing. That's really great. And congratulations on that work, and bon continuation. That's fantastic. I'll come back to you a little later on. But now I'd like to go to Zanfina to hear from you regarding really the rationale behind the cost effectiveness study on Lp(a) testing, and why this economic evidence is so crucial from an advocacy perspective. And again, you will be talking about that whole dimension that thinks about the societal impact, the impact on the individual as well. Over to you, Zanfina.
Thanks, Nicola. And Florian and Inés set the scene very nicely. So why we are here to hear about the evidence that will support a reimbursement process for Lp(a) testing in population. So today I'm going to be presenting the first cost effectiveness study on Lp(a) testing in high-income countries. So just to highlight the funding, the study was commissioned and funded by FH Europe Foundation as a part of international international task force, and also from the National Health and Medical Research Council in Australia. I would like to acknowledge all the authors. I'm presenting this work on behalf of amazing work of all specialists that have done. So just to set up the scene, what I'm going to be talking today is about current cardiovascular disease risk prediction tool, why health economics is important for decision-making, and then I will illustrate the results and what do they mean for implication and reimbursement process in Europe and globally. So the current CVD risk prediction tools, as you've seen from Florian, he highlighted very nicely what are the current risk prediction tools that don't include Lp(a) testing. And we know from the evidence is that current prevention approaches are mostly initiated in late life pre-disease trajectory. So if you can see this graph in here, majority of the people will start treatment at age 60 when it's too late. So the missed years of prevention, it's huge. So we are having a 20 years of missed prevention if somebody has already progressed disease. And we know that current clinical tools bias decision towards short-term decision-making. And we know that majority of these risk scores don't include cumulative impact of risk factors. What do I mean by that? What I mean by that if you go to a primary physician, they will measure your blood pressure, your cholesterol level at one point in time, but they are not aware of your cholesterol level from birth. So what we're trying to achieve is that include that information into the decision tool, because that will be a better way to predict the future events in cardiovascular disease. And we know that majority of these scores are influenced by age and gender, and modifiable risk factors have much more smaller impact. So what I'm talking here about modifiable risk factor is systolic blood pressure, cholesterol, diabetes, smoking, exercise, and so forth. And none of these CVD scores, at least the validated ones, measure Lp(a) to predict the risk of outcomes. And we know from Florian's presentation that Lp(a) is an independent causal risk factor for atherosclerotic disease. So now shifting the gears, why health economics? So why we do health economics? Aging population, number of new technologies that comes every year in the market, and we have all the time new diseases. So as a health economist, we always have to make choices and priorities. And we know from evidence that not all prevention strategies are effective. So there is a growing gap what medicine can do and what is economically feasible to do. So if a technology would be cost effective in Austria or in Germany, probably it will not be cost effective in Lebanon or Iran. So we always have to take in consideration that information. And there is a large increase in resources devoted to technology assessment, and that's why health economics is very important. In health economics, I just want to reiterate that we always look, is there a balance between costs and benefits? So we always want to look at treatment that individuals received, co-treatment, complications, and adverse events. We always include those information when we do those calculations. On the other hand, in terms of benefits, we're always interested to know clinical impact in terms of if you had a heart attack or stroke, but also we are very keen to understand whether if you receive treatment, whether you have a better quality of life, if you have a better psychosocial life, and also gains for patients in terms of productivity, returning to work. In health economics, we usually tend to measure something called incremental cost effectiveness ratio, and we always compare it to the standard of care. So let's assume now standard of care, it's no Lp(a) testing compared to a better situation when we have Lp(a) testing. So we always would measure cost of people with and without Lp(a) testing, but also outcomes. And then we calculate costs required to achieve an extra unit of outcomes. As a health economist, we usually like to present our results in cost effectiveness plane. And when you present the results in cost effectiveness plane, you have here in a vertical axis, you have cost, and in horizontal axis, you have outcomes. Usually technologies that are more beneficial and less costly, they are cost saving. So there is no brainer. We would like to implement that at the larger scale. But usually majority of new technologies that are more beneficial, but they're cost money. And a lot of countries that have different threshold, which we call cost effectiveness threshold. For example, in UK, thresholds are between 20,000 to 30,000 pounds per extra unit of gain. So if a technology, if you see this purple line, is above the threshold, then the government will not implement that technology. Everything below the red line would be considered cost effective. So now I would like to introduce you to our first cost effectiveness analysis. So our aim was to develop a novel health economic model that simulate primary and secondary prevention of cardiovascular disease. We were evaluating cost effectiveness of Lp(a) testing in a primary prevention population where testing is followed by a change or adjustment of the prevention management plan, including treatment or other cardiovascular factors compared to current practice. So we've used the largest data set that exists at this point in time, UK Biobank, with around 500,000 people. And we have looked at a primary, and we randomly selected 10,000 people who were aged 40 to 69. The reason why we've chosen 40 to 69 is that UK Biobank have a very little group of people who are below 40. And on top of it, majority of the risk scores that we have now, they are function from age 40 and above. So what's happening here? So we have 10,000 individuals, and we have used this score 2, which classify peoples in very high risk. And if you are very high risk, you are treated with high intensity treatment for your cholesterol level and systolic blood pressure. And then if you are high risk of lower, you are just standard of care, you don't receive anything. But now this group of population had Lp(a) testing, and we have actually included in a score 2 Lp(a) testing. And based on inclusion, we have managed to change people trajectories if Lp(a) testing was included. So you can see here that out of 10,000 individuals that were randomly selected from the UK Biobank, we have modified their risk trajectories by looking for Lp(a). So what we've done here, so we aged individuals without cardiovascular disease between ages 40 to 69, and usually mathematically we follow them until the age 85. We follow them until age 85 because that's the life expectancy of someone in Australia and in UK. So risk of events was proportional to cumulative LDL-C, systolic blood pressure, smoking, and lipoprotein A, as well as diabetes status. So risk of events and risk factors data was derived directly from UK Biobank, and utilities, quality of life, and cost from published sources. So this is the model. It has 9 health states. So we are capturing events such as diabetes, if you had a heart attack or stroke, or if you die, or any combination of those. So in health economics, it's very important to define the perspective, because the perspective actually defines what type of costs are included when we make calculation and inform the governments. So for example, from a direct healthcare costs or healthcare perspective, majority of the countries make decision only from a healthcare perspective. And what does healthcare perspective includes? Includes testing, includes acute costs. For example, if you have a heart attack, you will be in hospital, and then you would have medication treatment, and then you will have post post-discharge, you will have chronic management costs, which will be lab tests, seeing your physicians, treatment, and rehabilitation. But there are also direct non-medical costs, which sometimes very rarely we include because it's very difficult to capture. And what does that include? It includes carer's time, but also it includes the cost that you spend going back and forth to see your primary physician or to see your specialist. A more holistic view to look at a disease burden, it's societal perspective. So societal perspective not only include healthcare perspective, but also include impact, what is disease having on you in terms of returning to work. So lost earning or death prior to retirement, workforce dropouts due to illness, absenteeism, missing work, and also presenteeism, meaning that you might be at work, but you are not be able to work properly. To illustrate this situation, I would like to highlight a real-life situation of one of our great FH Europe ambassador, Mark Rieken, who at age 39-year-old, he had a heart attack, which was diagnosed via ACG scan and cycle test in a cardiology center. And then he had to do a CT scan in order to confirm the diagnosis and look for root cause. And then diagnosis was confirmed and concluded in incident, all in order. And then he had to do catheterization because of doubts on conclusion. Situation was very critical. 4 coronary arteries, over 99% of them were blocked. Open heart surgery, 7 bypasses. So all those things highlighted in red could have been theoretically been prevented if LPA was tested earlier. In terms of societal perspective, so heart attack at age 39 in March 2014, physical complaints and low energy, dismissed from work by a company doctor. So Mark was not able anymore to work. Open heart surgery in 2014, with approximately 10-month recovery in which energy was very low, not fit for work, not able to tolerate the energy of his young children, not able to attend social activities. Again, all of these would have been lowered or prevented if Lp(a) was tested very early. So here are the first results, or how we call it in health economics, base case results. So what we've shown here that we did analysis first for Australia and United Kingdom, but then we adopted results to high-income countries. You can see here that we have in these 10,000 individuals, we have prevented 38 stroke, and we have gained in quality of life. This is a metric that we use in health economics, which is a combination of your quality of life, how you feel, and also life years, meaning quality and quantity together. So you can see here from a societal perspective in Australia, Lp(a) testing is cost saving. In United Kingdom, quality gains were even higher. And when we look incremental cost effectiveness ratio, both from healthcare and societal perspective was cost saving. So not only saving lives, but also saving cost to the healthcare system and to the society in general. To bring it back to the cost effectiveness plane for Lp(a) testing, healthcare perspective. So in Australia, from a healthcare perspective, it was cost effective. From UK, was cost saving. So more beneficial and was actually providing saving cost to the healthcare. As mentioned before, we have adopted, I'm very excited to present results to the high-income countries. You can see here that cost saved per person if Lp(a) testing was implemented. In US, for example, it was $116, and in Germany was around 51 euros per person. So if we look at from a societal perspective, the gains are even larger. For example, in US, it goes almost around $500. In Germany, it goes $182, and in Italy and Spain is around $70 euros per person. So cost saved per person is total healthcare cost plus indirect cost divided by 10,000 people in the cohort that we have analyzed. So it's I'm very happy to share that for both genders results are very, very similar, and from both countries it is cost saving. And also it's important to highlight that currently in this analysis we have used a threshold for Lp(a) of 109 millimole or 90 milligram per deciliter. We have chosen this because these were some of the thresholds that are used currently in new trials for new treatments for Lp(a). But look at this, if we would lower the threshold for Lp(a), the savings in terms of changing trajectories of people who have high Lp(a), in terms of saving heart attacks, in terms of saving quality of life, are much more huge in terms of a societal perspective. So we're saving much more if we are lowering the threshold. So what does this mean in terms of population level? So then we said, how about if we look at the total population that is now globally, the countries that we have included. So if we would have put Lp(a) testing, we wanted to know how many events we would avert in a group of population 40 to 69. For example, in United States, we would avert around 500,000 of events. In France, almost 100,000 events. In Germany, above 100,000 events. In terms of quality adjusted life years, this is even larger. So the gains that we are gaining with Lp(a) testing early, it's huge in terms of, if we put those figures in terms of at the population level. In terms of costs, you can see that US, for example, from a healthcare perspective, would save around 40 billion. In Germany would save around 1.5 billion. France would save almost 1 billion in terms of healthcare if we would implement Lp(a) testing. Look at here from a societal perspective, those savings go beyond and above. So in United States it's around 60 billion, in Germany 5.3 billion, and in France 3 billion savings if Lp(a) testing would be implemented at the population level. So to summarize this, from these results, we've seen that Lp(a) testing is cost-saving in all high-income countries from both healthcare and societal perspective, finding cost-effective strategies to improve the prevention for cardiovascular disease. It's a public health priority, and these results are showing that we are not only saving costs, but we are saving lives. Findings are primarily based in high-income countries, so we have to be very careful how this information will be implemented in low and middle-income countries, but we are very confident that the similar results, there will be just changes in terms of the cost, but the results would be quite similar in terms of we would get cost-saving results. And our work adds to growing body of evidence supporting implementation of Lp(a) testing in clinical practice, even without a specific treatment for Lp(a) itself. To summarize, implementing systematic Lp(a) testing requires a shift in how we think about prevention. If we address CVD risk factor the way we do clean water, seat belts, and vaccination, it could transform cardiovascular outcomes for millions of people worldwide. So thank you very much, and I'm happy to hear if you have any questions.
Fantastic, Zanfina. That was a really, really clear overview, very compelling evidence, and I think brought alive very nicely with the example of one of the FH Foundation ambassadors in the Lp(a) space. We're now going to shift gears a little bit and talk about the Brussels Declaration, the Brussels International Declaration on Lp(a) testing and management. We're just currently putting the final touches to that political document, and we'll come back to the entire community and indeed all of you as participants, not only for endorsement. You can endorse as an organization, as an individual, but also to look at how you can circulate it widely and make sure that it comes to life, that it's a blueprint for policymakers. What this is all about, in a nutshell, 5 key asks to policymakers: inclusion of elevated Lp(a) testing and management in cardiovascular health plans at all levels, appropriate investment, policies and programs in Lp(a) testing and management based on the compelling evidence we've heard just now in relation to the cost effectiveness study, and really demonstrating clearly the cost savings and the societal impact. Leadership and commitment to Lp(a) testing once in a lifetime at an early stage with full reimbursement. And crucially, ensuring testing is undertaken in the context of global cardiovascular risk assessment with personalised roadmaps and without fear of discrimination. This was a topic that came up very frequently at our summit last week. This risk of being discriminated against on the grounds of health status is something that we really need to tackle, and to drive investment in public and healthcare professional education to increase overall awareness about elevated Lp(a) and its huge impact on cardiovascular health, and clearly looking at the implementation of those asks, bringing them to reality, the current digital transformation, responsible health data sharing, AI will clearly support. And there's also a commitment amongst the community to shared learning across countries, monitoring and evaluation, so we can really chart progress in the implementation of the declaration year on year moving forward. So this is where we are in a nutshell. And I would really love to invite all of our speakers to comment on this very briefly, and particularly how you will bring it to life in your environment with your networks to really beat the drum and make sure that shift, that change happens. Can I kick off with Zanfina, please?
So, as mentioned before, I think these results are quite relevant to any country who would like to do a primary prevention. And I also wanted to highlight that a lot of questions were around, does this include other cardiovascular risks? And what kind of modification we are doing for those with a high Lp(a). I just want to answer that because it's very important. Yes, all the other traditional risk factors are included in this analysis because we don't think of Lp(a) in isolation. And secondly, if someone has a high elevated Lp(a), we would suggest them to be treated more aggressively with a statin treatment or a blood pressure treatment, to stop smoking and do exercise. And in terms of health economics, this is a very eye-opening. This is a new way how we should think about primary prevention, because cholesterol levels are a silent killer in society. And we know that primary physicians very rarely intervene when you have a high cholesterol, and let alone Lp(a). So I think this is a stepping stone to think about primary prevention in a more global scale, rather than traditional risk factors, but including Lp(a) as something that would add benefit and would society would gain overall in terms of health, but in terms of savings.
Terrific. And that's a very strong message in the international declaration, and will be expanded on even further in a complementary document that Florian will no doubt mention in a few moments as well. Let me go to you, Inese, from where you're sitting in Latvia. Where do you see the value of the international declaration? In a nutshell, how are you going to use it?
Yeah, I think it's not just something that has been done, and great work behind all of it has been done, so you can present it today, but it's actually just a beginning. It's just a beginning for all of us. A lot of work ahead as well for patient representatives, patient organizations, as well for professionals, for doctors, as well for decision makers, as well for health economists. So it's very good that we have this document, so almost ready. So, but a lot of work ahead. But what I wanted to mention specifically is regarding the costs. We heard a lot of costs. And I know it's important for decision makers because they see it as costs or benefits or losses or investment. But for us patients, it's all about lives. We are not talking about saved costs, we are talking about saved lives. And in the case of Lp(a), I see that it's a perfect match because we can save as well costs, as well we can save also patient lives. So I'm really looking very much forward, and I would be also happy to use these data in Latvia, also in collaboration and discussion, also with our decision makers, while also preparing cardiovascular disease prevention plan and other policy documents. So it's very obvious what we have. And also, as Zanfina mentioned, those data should be also probably most likely adapted also for countries, but we can use it also as very basics. So, and one more thing I'd like also to mention, awareness, the word awareness, because no testing will help us if there will be no awareness, no education, no understanding on all levels, starting from patients until the decision makers, what is LPA, how dangerous it is, and also what we can do about it today in order to prevent all the not so good outcomes in the future. So it's also very important to remember this one.
Fantastic, Ines. And it sounds as if you've already got in your own mind the campaign strategy in Latvia, and you're absolutely right. It's the beginning, it's the starting point. We will have the declaration, we have all of the assets, let's say, from the summit, the cost effectiveness study, a lot of work that's happened so far, bringing that all together at national level in a smart way through real advocacy with decision makers. Super. Thank you very much for that. Moving now to Florian, where are you sitting with the declaration? Please, over to you.
I consider it extremely important that we are moving now, talking about from cardiovascular disease, that we are moving to cardiovascular health, and even policymakers talking nowadays about cardiovascular health. And I think with the cost effectiveness analysis, where we show that it's cost saving, this is a good support for the entire situation, and this is really good news. And of course, I will talk to our policymakers in Austria, but also outside of Austria. If someone wants me to talk to them, I will be happy to do that. I will preach what we have heard today, and I will take a lot of my time to use it. It's important that as a scientist that we are going down from our ivory tower and coming to those people whom we have to, let's say, educate, raise the awareness, and bringing them the arguments that they understand it. And it was also mentioned that we need material for our people with lived experience with high Lp(a), that it's explained in a way that it's understandable by our citizens, because then otherwise we cannot reach them. I think there's a lot of things to do. It's a long way to go, but I'm happy when many people join us.
Fantastic. That's a very clear message, Professor Kronenberg. And obviously in your role as chair of the International Task Force, there'll be a lot of oversight also at global level. And one thing that was really very, very reassuring in a way at the summit last week was the commitment of the WHO representative to really look at some change at that level, because at the moment Lp(a) is invisible in WHO instruments. So that's another important angle as well. We've got a couple of minutes just to address one or two questions. We have a question, of course, in an ideal world, we would test everyone in primary prevention, but in reality, some countries aren't even testing those at highest risk in secondary prevention. Surely we have to start there. Florian, back to you for your thoughts on that.
Yeah, I think this testing in high-risk populations, as it was recommended already since 2010, is still in place. We should do that, yeah, that we test in those with a personal history of or a family history of cardiovascular disease, or those who have high Lp(a). This is all true, yeah, but in the long run, we should go away from this secondary prevention setting, move forward to primary prevention setting, because here we can here we can avoid a lot of tragedy. Yeah.
Sure, sure. Anything to add, Zanfina, Inese?
I think I do understand the question that they said in some countries, not even cholesterol level is measured or blood pressure. Should we start there? I think we shouldn't, as I said, we shouldn't see Lp(a) in isolation. We should see Lp(a) in combination with all the other traditional risk factors. The reason why we're advocating for that is because it's a very cheap test. What is actually going to be an issue is training those physicians to understand the importance of primary prevention, not for only Lp(a), but also for hypercholesterolemia and hypertension.
Yeah, sure. And is anything from your side?
Yes, I also totally agree to our colleagues. And again, I want to mention this magic word, which is called awareness, so that people are aware, that they are encouraged to do that, and that they do understand also the benefits and the goals. So what we just heard also at the beginning, so I have high Lp(a), so what? So people should understand that we can do a lot already now in order to prevent. And yeah, hopefully in the future also we will have effective treatment for Lp(a).
Yeah.
And yes.
Great. One more question. I know we have several other questions and we will focus on responding to those after the webinar, but there's one that's particularly interesting, I think. If it's a genetic disorder and can be shown with a simple test, wouldn't it be more convenient to test children for Lp(a)? It can then be combined with other tests, and it's easier for children to learn a good lifestyle rather than for adults to perhaps adjust their lifestyle. And that, again, was a message from the summit, from the patient representatives there. Florian, just very, very briefly, your perspective on this.
You gave us already the answer. Because when you can adjust for that, and some people are always coming up with the argument we might frighten people, but this is not necessarily the case. When you talk to patient representative, they tell us they are happy that they know it now and that they can act now, change their lifestyle before a tragedy occurs.
Yeah, sure.
Testing early is a good idea, I think. Yeah.
Absolutely. And I can see nodding from our fellow speakers. So yeah, I think that's definitely a meeting of minds. And that's something, again, that FH Europe Foundation and the International Task Force will need to explore in even further detail moving forward. I've mentioned the International Declaration on Lp(a) testing and management. And of course, that didn't fall out of the sky. It's the basis of very important, careful, considered work of the International Task Force and the coordination of FH Europe Foundation, building on the important work that was undertaken in previous years, focusing on FH pediatric screening, with a technical meeting under the Slovenian EU presidency, the Prague Declaration on FH pediatric screening, and a meeting in the Senate under the Prague under the Czech EU presidency, and then more recently some very careful political work on the idea of a European action plan on cardiovascular health, emulating the Beating Cancer Plan. A lot of progress has been made there, and we want to make sure that Lp(a) is included there as well. And this we felt very encouraged by in the context of the Hungarian Council conclusions at the end of last year that mentioned for the first time inherited lipids and the importance of testing for elevated Lp(a). So the scene is set. We have a very, very exciting political backdrop to really move forward on the topics that we've been talking about in the context of today's meeting. We will follow up with the recordings, with a summary report responding to all of the questions. And it remains for me in the last few seconds to give a warm, warm thanks to all of our excellent speakers for presenting really a very, very strong and compelling case for testing and person-centered management of elevated Lp(a) from a patient's perspective, from a science perspective, from a cost-benefit perspective. I think this was really, really super valuable. I wish you all pleasant days. Thank you very much for joining us, and we will definitely be in touch with the International Declaration. Thank you. And again, please do send us your thoughts, your evaluation by completing the survey. Thank you very much.